for the next one. Okay. So this is another important topic. I like to start from here. This is a paper which is a seminal paper. You know this definition by our colleague English speakers. This is a paper which was published by Michael Larsen and his group, Dr. Block and Michael Larsen, where they showed that after the introduction of anti-VEGF drugs in clinical practice, the reality of visual acuity loss, of blindness, was significantly reduced. And this is important because using this slide, this only slide, we should ask to our administrators and to our politicians to give us money, because there is no other specialty where you can show that in a few years ophthalmology was able to change the reality for our patients. Blindness, if you do your treatment well, like they do in Denmark, where they are well organized, and they use drugs, they can do whatever, you can have this significant reduction of visual loss. And this is only because anti-VEGF were introduced in clinical practice. So we need to have money enough for doing that. This must be used by all the eye doctors in the world in order to have from our administrators what we need. Unfortunately, I don't know how is your experience, but in my experience, when you talk to politicians, when you talk to the administrators, you talk about vision, about sight, and this is not life. And for the administrator, it's much easier to speak about life. They understand well what we're speaking about. You know, they can understand well why they should give more money to oncologists, hematologists, or whatever. Because they speak about life. So they say, if you give me this drug, I can reduce the death from this disease significantly, and so please give me money. We cannot speak about that because we do another job. But this is so important because, as you know very well, the perception of blindness by the patient is considered at the highest level of the quality of life. Studies were done about the perception of visual acuity loss of blindness by the patient, and it is at the same level of dialysis. So for a patient to be obliged to make dialysis is considered at the same level or less level than blindness, than visual loss. So we should use this in order to have what we need, okay, for our patients. So I think you know everyone I think knows these concepts. Anti-VEGF is a concept already well known. I'm happy to say that it is coming from researches that were done mainly by Napoleone Ferrara, who is an Italian from Sicily, pharmacologist who moved from Italy, and he went to California. He worked for Genentech for many years, and working on the idea of Folkman, of Judah Folkman, he was able to identify vascular endothelial growth factor, and was able to produce an antibody who was able to link with vascular endothelial growth factor, making vascular endothelial growth factor unable to produce these effects on the cells. This is the concept. So he produced first the antibody, the monoclonal antibody, which was obtained in the animal. So first identified vascular endothelial growth factor, injected vascular endothelial growth factor in the animal. He obtained the antibody, and this this antibody was treated, humanized, as we say, and finally he had this molecule, which is bevacizumab. As you know, bevacizumab was used for first as an official indication for treating patients with colorectal cancer, metastatic colorectal cancer. I don't know if you know the story, how the story of bevacizumab was happening. So Napoleone Ferrara produced that bevacizumab, and in the meantime, he asked to Mordenti, who was another researcher, to make a study to see if using bevacizumab inside the eye, it could be possible to have bevacizumab at the target tissue, which was choroid capillaris. Okay? But he did not have this animal model inside genitals, so he could not do a direct evaluation of the efficacy of bevacizumab inside the eye, and he asked his colleague, Mordenti is the name, to make a study trying to see if bevacizumab was able to reach the choroid capillaris if injected inside the eye. Mordenti did not use bevacizumab for making the study, used an antibody with the same body weight, first. And second, did not use an animal with a damage of the macula. He used an animal without any damage to the macula, and he did the evaluation of the presence of bevacizumab inside the different retinal tissue, like layers of the retina, without considering bevacizumab and without considering an animal with some kind of AMD model. As a consequence of that, Mordenti told to Napoleone Ferrara, Napoleone, bevacizumab does not reach enough the choroid capillaris. Therefore, you need to make another drug. And starting from that point, ranibizumab was produced. So, starting from the antibody, he was able to cut the antibody and using this antibody fragment, and this is ranibizumab. In the meantime, they started with the studies using ranibizumab, but somebody waiting for the results of these studies, ranibizumab was not available at that time, started, Phil Rosenfeld was the first one, started to use bevacizumab for treating patients with AMD. First, systemically, and then inside the eye. And this was the reason why, at a certain point, the question bevacizumab versus ranibizumab exploded. Because Phil Rosenfeld started to see some good results using bevacizumab. Ranibizumab is still not available. And today, we have a world where everybody knows everything, and the use of bevacizumab started to be very common wherever. And the main point was this, unfortunately, this mistake made by Mordenti, who did not give to Napoleone the right information. Because maybe it would be possible to modify the molecule in order to arrive to the similar results without doing all the work that was done by Napoleone. Okay. The problem is, okay, anti-VEGF is working well, no question about, and we have these two seminal papers published by New England Journal of Medicine where the use of the anti-VEGF was done inside patients with classic and occult new vessels. In one case against PDT, in the other case with shell control. And the two studies show that using this drug, ranibizumab, it was possible to have this huge improvement of visual acuity. I remember when, before this study, when we were speaking about treatment of AMD, we were always speaking about percentage of eyes losing more or less than, no? Because PDT was able to reduce a bit the percentage of eyes with important visual loss. And seeing these lines with an improvement of visual acuity was a revolution for everybody. But, again, we come back to the problem of the companies. The company in this case, in order to show the efficacy, did this model of treatment, which was difficult to be replicated in clinical practice, because these studies were done using monthly injections, and these are the results after 24 months, after 2 years. So, no way. Treating patients with monthly injections of ranibizumab means that you have a significant improvement of visual acuity. But unfortunately, after Marina and Duncan studies publication, starting with using this drug in clinical practice, we realized that monthly injections was impossible. It's impossible to have these patients treated each month with an injection. 8 years old, 90 years old, 75 years old, the family around the patient that needs to bring the patient each time, each month, which is a system that doesn't work. So after the publication of the trials, the efforts were done to understand how we could use the same drugs with different algorithms, with different modalities. Starting from the point that monthly injections is impossible to be done. And one of the main problems that I have today with my patients is also if you are very good respecting all the timing, the controls, whatever. It happens to me many times that I see some patient and I realize that it's 1 year that I'm not seeing him, or have 1 or 2 years. And when you ask to your patient, oh my God, lady, but it's 2 years that we are not in touch. What did happen? Why you did not come? You had very good results. You were stabilizing your visual acuity. Everything was going well. Why you did not come again? And the answer is always the same. I could not follow this regimen of treatment. I was tired out. I did not want to ask my son, my daughter, my grandson to bring me in the hospital each time he or she had to avoid to go to work, the problems that you know very well. And this is a problem. This is, I think today maybe it's the main problem. After some time, the patient is tired out. And maybe we need to make some kind of teaching. Maybe we need the help of companies to teach our patients, to inform them the importance of this continuity in the controls, in the treatment, and so on. Because at a certain point, the patient does not want to follow our indications. And I can understand that. Any comment on that? Do you leave these problems, you too? Adrian?
Very much so. Also, cost is so not just that, comorbidities, so they often have other problems. If you all end up in hospital for 6 months, you don't see them, and then they have gone downhill in the meantime. And I think the big issue is also cost and accessibility.
Any other comment on that? This is one of the main problems today. We have what we need for having very good results, but many times you are not able to use them as you should for this kind of problems. Okay, so established that monthly injections was impossible to be done, we started to think about new modalities, new ideas, and so on. The PRN treatment, the rule of 3 loading phase injections and then PRN was invented, was something that was not coming from Marina and Duncan. Marina and Duncan were only able to show that the improvement, the main improvement was during the 3 months. So starting from this 3 months improvement, a mathematical model was done, and it was proposed to have 3 injections, loading phase, and then PRN. But this was not shown by the studies. because the study were monthly injection forever. So the PRN was something that in practice was proposed in order to make the treatments possible for everyone. But more recently, this concept of the treat and extend regimen was introduced. We will try to see it a bit better. How many of you are doing treatment and extend regimen for treating your patients? So few, really few. So the great majority of you, what are you doing? PRN?
Yeah.
Who is doing PRN? Okay. So the PRN concept is I do the injection whenever I see that there is an indication. It's a very simple concept. And you have, in this case, a low risk of overtreatment, but you have monthly visits in order to make correctly the PRN. You need to see your patients anyway monthly. So the timing is anyway the same. You have less predictable injection workload, lower disease control stability, and it's a very expensive methodology. Here you have the graph where all the different algorithms of treatment are presented together, and you see always that this monthly modality is anyway the best. So what we need to do is to try to be nearby the monthly modality in order to guarantee enough good results but apply in clinical practice. This is the peer study. I will present you all the proposals that were done during this year. The peer, I think you are familiar with that, it's already an old study, this one. The Pronto study, again, all these attempts were done in order to make the treatment possible, trying to reach similar efficacy than the monthly injection scheme. The Sustain study was similar. As you see, there was an improvement after 3 months, and then some kind of reduction of visual acuity, but no other treatments reached the same level of efficacy of the monthly injections. So the CAT, I think you know the CAT study, where the different drugs were compared together, bevacizumab and ranibizumab were compared one against each other, and the EVAN study that was done in Great Britain, Usha Chakravarti was the main researcher for that, and also this study showed similar results. But what was interesting from the EVAN study was that they did some kind of PRN modality, but each time that they saw the indication for treatment, they did 3 injections. So they repeated this loading phase each time that there was an indication. In this way, as you see, the results were relatively good, much better than what we usually have with PRN. So maybe if you are in some way increasing the number of injections, and you are reaching the level of number which is near the monthly injections, you have better results. The concept is always simple. So in the EVAN trials, the PRN was equivalent to monthly treatment, but the PRN was not the PRN that we usually use for treating our patients. And this is for aflibercept, for IDEA. You see that the results were more or less similar, but the timing of injections in this case was each 60 days. So the concept of treat and extend was introduced more recently and is produced by the brain of Freud. The concept is that whenever you are treating your patient and you see that there is an improvement, you must continue your injection monthly, and then you can if you are stabilized, if you have the same result at control, you can have a control 1 week later, considering the monthly controls, and then 15 days later, in order to expand the timing between one procedure and the other. But when you see the patient, you must treat him or her. So this is the novelty. This is not PRN. This is after a certain time, you must inject your patient anyway. If I imagine to apply this model in my country, I would have legal issues to be faced. Because if I have a problem coming out from an injection done on a dry regimen, only on the basis of the treat and extend model, the judge will ask me, so there was no indication for injection, why you did that? And then you have also complications, so you are at risk of having legal issues. Adrian, how is it here?
I think the legal aspect is probably not so obvious.
Here.
In many parts of Asia, I don't know about Vietnam, but in Southeast Asia, like Singapore, Indonesia, I think that is not the main reason why the treat and extend is not done. Rather, the patients themselves are reluctant to receive the treatment when their vision is relatively good and there's no food.
Any other opinion about that? Anyway, at the moment, considering all the positive and negative aspects of the treat and extend modality, I think that today it must be considered the best model for treating our patients. Here you have the modality of doing that. Whenever you have this kind of good stabilization, you can span the timing between the procedures. And on the opposite, whenever you have some kind of worsening, we need to start again with monthly injections. So you need to come back to the same treatment modality. So the benefits of treat and extend, you have here the list of the advantages: fewer recurrences, more likely to keep retina dry, less patients visit, more proactive, reduced risk of hemorrhage, adherence, reduced cost, better disease control stability, individualized to patient, and more predictable injection workflow. These advantages over treatment, because you are injecting an eye that does not need that, does not identify the patient who is very stable without treatment and increase the chance of getting blood vessel. I must be completely sincere with you. I do not like it because I like to see the patient and to decide what to do. And I think that a doctor has this is the job of the doctor. So I do understand all the reasons that are here and here, but I do not like it. I do not feel well when I need to inject a patient without seeing any indication from that, only on the basis of the model. This is an opinion. This is the reason why I don't like it. But I recognize that these are the advantages and these are the disadvantages. You want to say something? You want to say something?
Me?
Yeah.
No.
No, I thought you were saying, no, sorry.
That's okay. I think you said it's specific. I'm a bit biased because I'm originally from Australia, and in Australia we retinal specialists there really have an uptake very high of treatment extend. It's been found in both Mark-Lee's live retinal blindness database that the visual acuity outcomes are better with treatment extend. But yeah, I understand it's something obviously.
Oh, another concept is this one, the concept of atrophy, that the CAT study was able to show that there is a certain number of patients developing apathy, and this is higher than what we thought before. And we need to be careful about that. And I was showing you, using the OCT angiography, the importance that can have new vessels when you have some atrophy. These quiescent new vessels, maybe they are important for to maintain the retina trophic. And if you treat patients with these quiescent new vessels with anti-VEGF, the risk is that you are producing some worsening of retinopathy. So there is also this other study which was done in France, the Lucas study, where the algorithm of treatment was practically a treat and extend modality. And they found very good results. Visual acuity at 1 year was comparable to those of other clinical trials with monthly treatment, using the treat and extend modality. So another indirect evidence that treat and extend is working well. So this is a paper by Bailey-Freund. Treat and extend regimen produces a greater vision improvements compared with PRM over a period ranging from 6 months to 36 months, 3 years. And this is the results of the study that were considered by Bailey-Freund in this publication. Again, treatment extend versus pro-renatal, and this is a comparative study at 2 years. And again, mean change in best corrected visual acuity was significantly greater in treat and extend regimen. So all these papers, all these experiences are in the same direction. Treat and extend produces better results compared with PRM, no complaint. And another one is an experience made by, this is always the same kind, and this is after this experience was done by Truth in Switzerland, and they had a group of patients that were treated with the PRM procedure, and these cohort of patients were switched to treat and extend regimen, and what they found is this: these patients were going down, were worsening significantly. When there was the switch to treat and extend regimen, the quality of treatment showed much better results. Another indirect evidence that treat and extend regimen at the moment must be considered the best. And this is the paper by Ruth. So in conclusion, anti-VEGF are the standard first-line therapy for neovascular AMD. I think that the evidence of that is enough, more than enough. Individualized treatment protocols provide a reasonable alternative to monthly injections, and the treatment and extend modality algorithm of treatment at the moment seems to be the best way of combining an approach which is applicable with results that are similar to monthly injections. So I think this is the last slide. Yes. If you want to address some question, I'm here for answering. Please.
As you said, yes, treat and extend is the best approach to treat a patient with AMD. Although in practical, real life, what I do is that I treat until it is dry, and then I extend with a PRM approach. So if I see them still dry, I don't treat. I kind of do.
So you make the
mix and mix.
Extend and treat.
Yeah.
So yeah, that is what I'm doing in clinical practice, me too, which is Yes, first I do monthly controls and injections whenever needed, like the PRN, and then I extend the timing between controls.
If I see that they're still dry,
I don't inject it. Please.
In your practice, what is your first line anti-VEGF for treating AMD? Okay,
Ranibizumab, no? What do you think about?
Put it in the maybe you could.
No, I think both drugs are very good. Really, I'm lucky because in my region, I can use only labeled drugs. So, no question that ranibizumab and Eylea are the two drugs that I'm using. And I'm now serious, maybe because of the history of the drug, because of the experience I've done. But I'm more, I use more ranibizumab than Eylea. But I must recognize that both drugs are very efficacious, very good, with a very good safety profile. And I think that really they changed completely the prognosis. What I showed as the first slide is the history. This is history of medicine. Maybe we are not realizing that enough, but we are living a revolution. We live in a lucky phase of our life. I'm old enough to remember that we did nothing before. I was in a center in a department which was a referral center for AMD, but the cases with very good functional results after laser treatment for CMD in AMD were really few. Many times you were lucky because you were third level of referrals, third or fourth. So you could do whatever, and the patient understood already that it was a drama. Otherwise, the patients were always unhappy. It was really rare to have a happy patient for treatment or anything.
Do you have
do you have any experience with this kind?
So this is only for the study, in the trial.
It's not yet or something.
Not clinically, not yet, not clinically. In the study, you have the feeling that it's working well. We have some cases which were inside the study where you had some beautiful results. Probably it was the drug, and but I cannot say anything about the clinical application.
Do you use it at all combination still?
No, the only patients where I am used to use the combination steroids plus anti-VEGF is retinal vein occlusion, central retinal vein occlusion. When you have that very bad cases with ischemia and you have nothing to do, you inject with anti-VEGF, you don't see any results. You inject with steroids, you don't see results. And the patient is going really badly. In those cases, I inject both drugs together. I do first injection of anti-VEGF, and on the same session, I do injection of steroid. And in many of these cases, you see very beautiful morphologic results.
In CRVO.
Pardon?
In CRVO.
CRVO. But the functional results usually are not so good.
Have you tried combination with laser? In this case?
No, in those cases, many times I do laser for retinal ischemia for CRVO, for sure.
By steroids, do you mean prospects or?
Again, that's the same rule. In my region, I use only labeled drugs, so Autodex, which is labeled, triamcinolone is not. And so I use Autodex for as a steroid. I hope I use also, as in the famous study, Lumian for those patients that are always
in order to assess the reactivity of the disease, do you use OCT or you use BCVA or what?
Oh, usually I use OCT, and at the moment OCT and OCTA. And whenever you have the feeling that there is some discrepancy from functional results, or what you are seeing is not clear. I do also angiography. But at the moment, OCT and OCTA are the main instruments that I use for monitoring patients. We did a study in myopic eyes, in myopic CMD, which are a different story because, as you know, fluid myopic CMD is difficult to be seen, and the evaluation of activity is not always clear on the basis of OCT. And we did a study having as gold standard fluorescein angiography and using fluorescein angiography and OCT with blind observers, evaluators, and we found that at the moment of diagnosis, so the first exam, fluorescein angiography is needed. And you have a percentage of eyes where OCT is not able to produce the same results you have with fluorescein angiography. But during the follow-up, the percentage of eyes where there is a discrepancy between the gold standard and the OCT is going down. So, on the basis of this, we do always fluorescein angiography at the start, and we monitor our patient with OCT. This is for myopic CMD. But for AMD, the story is similar. Usually AMD is easier to be evaluated by OCT compared with myopic CMD.
You said that you use the PRA and extended visit regimen. So, what is the longest period that you follow up patient in this regimen?
I have to 3 months when the patient is going very well. And when after some time you have no recurrence, I can prolong to 4, 5, and then 6 months. But in the first time, 3 months is the maximum.
After 3 months and the patient is stable, so you schedule the patient back again?
Absolutely, he needs to come back. She needs to come back. Any other comments? Other, I amended 1 minute before. I think you cannot say badly stories about it.
As always, you've covered everything and also kept everyone engaged. First, join me in thanking Professor Francesco Bandello. Thank you, Francesco, and we wish you a safe journey back. We look forward to welcoming you to another association very, very soon. So I think you've all been very, very attentive today. Thank you for your questions, your discussions. It shows that you've been thinking about what has been taught, what has been said. A lot of you have your own rich experience, which I think we can all learn from and share with. So I encourage you tomorrow and the next 2 days also to continue. Tonight you have a deserved rest. Rest well for the sessions tomorrow, which begins at 9 o'clock in the morning. Now on your program, we have Dr. Chow, who was supposed to speak on screening of diabetic retinopathy, but she can't make it for the lecture. So Dr. Tai San from Thailand will give his talk first at 9 o'clock and 10 o'clock. Dr. Chow will then speak at 3 p.m. tomorrow. So sorry, we've had to change the order. But tomorrow morning at 9 o'clock, please be here. There will be breakfast served. No breakfast, I'm sorry. So you have to fend for yourself. And then by 9 o'clock, please be here. But before we leave, I hope you will join me just to thank our 2 translators who have worked so hard today while all of us are here listening and enjoying the talks. It's really difficult to concentrate and having to translate live for all of you. So please, thank you very much for a fantastic job today, and have a good rest this evening. We look forward to seeing you tomorrow at 9 o'clock. Thank you.